We invite citizens, people in communities, to work alongside people in services, and predominantly that work happens in primary care. It can happen anywhere. It can happen in accident and emergency, it can happen along integrated health and social care pathways, it can happen in care homes, it can happen in lots of different places, and we've done things in different places. But this conversation is about what happens in primary care. We're working at the moment with about 125 practices in 23 CCG areas around the country, and I guess what we've done is we've prototyped, and then we've taken that to the state of innovation, and now we're beginning to scale it. A piece of work that we did in 30 practices was funded by the big lottery, and you get big money by the big lottery to evaluate. So we spent the best part of £500,000 evaluating the work. We were able to show that people's health and well-being improved. 94% of people had improved mental well-being. We know that when that happens, people's resilience improves, and we know that when people's resilience improves, their physical health improves. The other thing that happened was, in the practices that did this work, the lives of staff improved. So we saw better recruitment into general practice, and I agree with the comment about this is about the primary care team. This is not just about GPs, but we saw practices who couldn't recruit GPs into post. The practices who were doing this work did, because they were doing something different, because they're good places to work. So we saw morale increase, we saw sickness drop. So there's something about the difference it makes to patients, the difference it makes to staff. We saw pressure lift across the system, so people's working lives got better. And what we stumbled upon, and this was not what we expected, was that practices could see a new business model. So that one of the first practices that invited us to get involved, invited us because they said that we are not financially viable. The practice manager drew me a graph and said, this is the point on the graph where we go bust. So we need to do something different. And what they did was they invited local people in the community to work alongside them. And by doing that, they increased their capacity. So this quote at the bottom is my most favourite quote. It's from a practice manager, business manager, in a practice called Robin Lane in Pudsey, and Mev says, we've increased our patient list by 4,500 people. We've seen no increase in primary or secondary care appointments, and they've also seen a reduction in accident and emergency admission because they do so that was a 57% increase in the list. So what we do, we invite local people to work alongside their practice. What we do is we work on developing a new collaborative relationship between citizens and services. We see people having parity. This is not a volunteer service. This is not an unpaid workforce. This is inviting people in to bring their gifts, their talents, their experience to do the things that matter. So we create an extended practice team, an extended practice family. And when you do that, it changes everything about the practice. It changes the way the practice works, because we've changed who's in the team. So we see needs are being met differently, and we know that it makes everyone's life better. When we go into general practice, we start to look at the data, and what happens is that you don't actually collect data about why people come to you, you collect data about what you do with them. We have different mechanisms now to collect that data, but a colleague of ours in Exeter, Neil, he spent 2 weeks just looking at why people came through his door, and these were the reasons. So he said 10 to 15% of people, minor illness, things that if you had a wise granny or maybe the local pharmacist could help you with. 10 to 15% anxious, low mood, fatigued, didn't need antidepressants, didn't need counselling, wasn't at that level of needing medical care, needed a friend, a job, somewhere to go on Wednesday morning. Another 10% were lifestyle-related things. So these were people who were coming because they were really unfit, they wanted to lose weight. The research tells us that if GPs advise people to lose weight, on average, people will put on £2 a year, because that's not how people lose weight. Losing weight's a social thing. This is the saddest number. 5% of the people who came to see Neil in a fortnight were people he thought wouldn't speak to another human being. And 5 to 10% of people were just getting old, but general practice is not in the business of saying, sorry, we can't help you anymore. And there aren't alternatives for people to offer. So what happens? This is Robin Lane practice. We worked with them 6 years ago now, and we worked with them for about 8 months. Today, they've still got 56 active practice health champions who every week deliver 30 weekly activities. So they have singing for the brain, they have poetry in a pint, they have young mums group, they have breastfeeding group, they have 24-hour, 7-day-a-week breastfeeding support. I can't keep up with it. Every time I go, there's something different. Over the lifetime that they've been running, there have been 63 different types of activities. Some things are annual. So the champions help with flu clinic. 300 people used to come to flu clinic on a Saturday. 900 people come to Saturday flu clinic. Because the champions just enhance what's already happening. So they use their Twitter networks, their Facebook networks. They help people on and off with quotes. They give them cups of tea. They talk to them in the bus station. They're just there. But everybody enjoys flu clinic now. So lots and lots of different things. The GP there says the story is that lives are transformed. We reach hundreds and hundreds of people every week. Now, most practices are wanting to stop that flow of people. What Rob and Lane want is they want people to come in and they want their needs to be met. So this is dealing with failure demand. It's dealing with the kind of people that really struggle to use general practice. But Linda says people are no longer isolated, they've made new friendships and they use services differently. And I took some people from the Hungarian Public Health Agency to Rob and Lane. And they said, can we see the practice? We'd shown them the Wellbeing Centre. And we went into the practice and I took this picture. There were 2 musicians in the waiting room in the practice, but there weren't any patients. And the managing partner said, what you need to do is go next door into the Wellbeing Centre. I just thought it was a fabulous image that they didn't actually need to be there because patients were doing something different. This picture at the bottom, I love this one. This is a practice in Gateshead and they wanted to do something around their long-term conditions. What they did was they said to the champions, how do we do this? How do we engage people locally with long-term conditions? And the champions said, well, these tend to be older people who've got multiple long-term conditions, and older people like to dance, so they organised a dance. The work is about resource and resourcefulness, so you only do what you can with what you've got in the room. What we had was a Bollywood dancing practice manager, we had some belly dancing practice nurses, we had a very well-loved GP and a very handsome GP. They gave them each dance cards and 250 people came to dance. This is about a practice doing some things differently. This is the only practice in Gateshead that could recruit to vacant GP posts. This is practice who have seen a reduction in attendance from people because people are doing things differently. We're working at the moment with a practice in Stockport. And they got this work up and running really, really quickly. They've got about 20 champions and they've absolutely transformed the work. But they do it in a non-NHS way, in a non-organisational way. So they're not saying, like, let's find our lonely people, let's give our lonely people a buddy and labelling people. What they do is they have a sign on the desk and it says, will you help us feed the birds? So if you're lonely, what a great excuse to have a conversation. So they walk up to the desk and they say, what's this about? And they're given a bird feeder. And then they take the bird feeder away and the champions come regularly to fill up the bird feeder. So they don't know that it's not a treatment. This is social. This is a different way of doing things. And I just think it's so neat that they know that that's how you need to be with people. We've worked with 25,000 people who give their time. People want to get something from this, they gain themselves and they give to others. This is about changing the identity of who is in general practice. When you change identity, you change culture. So this is culture change for us. And I think that that's something really different from some of the other things. You pick the thing that will work. You pick the thing that people are passionate about. I managed social prescribing schemes many, many years ago. They're absolutely fantastic. Health coaching is fantastic. Health trainers are fantastic. You've got to find the thing that will work locally. They can sit next to one another. So we're working in Dorset at the moment with 24 practices. We're hoping to, and many of those will have social prescribing as well as collaborative practice. I talked about the impact on staff. It does impact on people, it impacts on the practice and how the practice evolves, and it isn't social prescribing in terms of a link worker, it's but it does the things that social prescribing does. It is gentle and subversive organisational development. It's changing the practice family, and it's sustainable with our ongoing funding because it changes the way that people work. And one of the really important things is it works because it's meaningful and fun.
So what we did in Hertfordshire, specifically starting in West Hertfordshire, when the Better Care Fund became available, we got creative. And we said, what would make the difference in communities to build up community resilience, to signpost people to third sector and community organisations that they need, that would bring down the silo barriers that we experience as different public sector organisations and enable people to fulfil their own potential and get over those non-medical obstacles and challenges that make a huge difference to people's lives. Acknowledging that 10 to 20% absolute maximum of our health and well-being is anything to do with medical diagnoses. So much more of it depends on the wider determinants: housing, health, debt, isolation, sanitation, family dynamics. So many, many, many different things actually affect how well you are, and also how well you use the medical services for the medical bits. And we acknowledged that it all got a bit messed up, that people were coming, medicalising their non-medical needs and landing themselves on GPs who didn't really know how to recognise these things, what to do with them, but realised that they weren't able with their medical kit to help these individuals get past their problems and fulfil their potential. So we invented the Community Navigator Scheme. Imagined a group of resourceful individuals who probably come from a number of different professional backgrounds, all problem-solving, community-focused careers, who could act as people who would signpost vulnerable individuals to the resources that were available around them and co-produce with those people a personal plan to improve their journey. And we envisaged that those people wouldn't belong to health or local authority or the third sector. They would belong to all of us, and they would enable all of us develop a person-centred focus that was away from any of our particular silos. And it worked. And it was fantastic that we had that season of creativity. We engaged with all the different sectors, and we invited third sector around the table to engage their ideas and to challenge them to get themselves in a position where they could collaborate with one another within their localities, not in competition, but in facilitation of one another, and host a community navigator. So we started off with 5 different third sector organisations, some of which were already collaborations of local third sector organisations, working in 5 localities across West Hertfordshire, who were managed by a gentleman that was paid partly by local authority and partly by the CCG. And all of the professional barriers and I work for so-and-so started to disappear, and people started having on their name badges more than one organisation stuck on there. And it was fantastic because it meant that we were owning this together and moving it forward. So we started off with 5 navigators, then we went to 7, and now what's happened is that East and North Hertfordshire have thought this is a very good idea, and it's spread across there. Plus, it has invaded the hospital discharge teams so that we have community navigation at that point of vulnerability and crisis in people's lives, And we have joined up strategically with two of the biggest third sector providers who already have their own problem-solving, triage, go out and get alongside people workforce. It happens to be Age UK and Red Cross. So we are joining up different parts of the sector, and we have ended up, which is with what is probably the biggest social prescribing scheme in the country. And it's local, and all the practices and the GPs and the local organisations know their community navigator. They know their face. We know who we're referring to. And we have a database which hosts all these different solutions, all these social prescriptions, called Heart's Help, which can be accessed directly by the public, website, etc., or can sit there as a kept up-to-date repository of the answers which may form part of that co-produced solution for each individual. A wiry 40-year-old gentleman who used to come and see me, and we had a relationship, but I couldn't do much for him. He'd sacked the psychiatrist because he didn't feel they got the diagnosis right. He was out of work. Didn't know a lot about him, knew that he used cannabis, could smell that, and he'd come and he'd sort of wriggle around and he'd pleased to see me, and he'd leave, and I still hadn't helped him. Till one day he came in and he said, "Here, Doc, I've got to tell you something." He said, "Don't think you know this, but I'm a dad, and my son's 10 now, and it's getting really embarrassing, Doc, because he comes to see me every other weekend, and when he's feeling awkward, Doc, he doesn't want to sit down. He's noticing the damp and the dirt, and he's looking at me, and, well, Doc, he means everything to me. And I know I'm not much, but I really want to be a dad. I really want to be the father he's proud of, and I can't, Doc." Now, I hadn't realised that his housing was in this kind of pickle. But it was if I saw an iceberg emerge from the ocean and I saw the tip of it. Housing. Here is my place that I can connect with my patient's wider health needs. Clearly there's an iceberg that I can't see, haven't begun to understand in my relationship with him so far. If we can connect him and get his trust working on the housing, where might this go? I might actually start to understand what this gentleman needs. He might actually be empowered to move on in his journey and improve his lot and his son's lot. So, Community Navigator got to meet him. It was a little sticky to start with, and often this is the case because you're referring people who are not naturally connected with people that might help them. They find it hard to trust. They've been let down, and the last thing they're going to do anything with is a helpful piece of paper that gives them a number to ring or a website to look up with regard to help. They're not going to walk into the Citizens Advice Bureau. You know, there are just too many barriers and hurts to prevent them accessing. So when they get an interested human being building that bridge with them, it might be a little bit bumpy at first. There might need to be some skill on the part of that connector worker to actually enable that person to see this is a real opportunity. Let's give it a go. So my man gave it a go. And he allowed the navigator to bring the housing guys in. I mean, I think she took them in by the scruff of the neck, but it was a housing association locally, and said, "You've got to come and see the state of this accommodation." And it was filthy, and there was damp coming down and damp coming up, and the furniture's rotten, and it's smelly, and it's in a block. They're probably all just as bad. So they started working on the housing, and the men came in, and they worked on the damp from the bottom and the damp from the top and all the things that you have to do. And he came back, and he's reporting the story to me. And he said, "Here, Doc," he said, "it's great. I've learned how to do this. I've learned how to do that. I'm working alongside the blokes. They're a really great crowd." And he started to sound like he knew what he was doing. And I said, "Hey, would you ever consider picking up some voluntary work or even do a bit of a training scheme and look at moving into this kind of work?" "Yeah, Doc," he said, "I haven't thought about that." And then he comes back and he tells me about his son and how different his son is behaving because the place is clean. There's plans to rip out the kitchen and sort it. They organised a grant for a new cooker. And he was prioritised for the new kitchen ahead of others because of the work the navigator was doing with him. Then he comes back to me and said, here, Doc, we realised it wasn't just inside, it was outside the block too. The damp's crawling up all the outside. He said, and I realised we've got a job to do here. So I went round to everybody in my block and I said, OK, shall we do this together? He said, let's move the earth away and look at what we can do. He said, so Doc, I found out which plants I could lift, which plants I couldn't lift. And I'm like, so he's a horticulturalist now. And he said, and I talked to everybody in my block. And this bloke was a recluse. He was, you know, he didn't talk to everybody. He's now become some kind of community leader. And he said, even Mr. So-and-so is a right old weirdo. He's talking to me now. So there's a gentleman with enduring mental health problems who has now also been connected to the whole community. Absolutely fantastic. The next thing I hear is, he's only gone and found a job. Now, he doesn't like people a great deal. So the job that he's found, with a tip-off from the community navigator, enables him to be picked up about 5 o'clock in the morning, cleaned for 4 hours and be dropped off at 9 before the masses arrive. He is so happy. He has got the dignity of work. He has got a place in his community. The environment he's living in actually is life-giving to him, and that restored dignity of fatherhood just melts me when I see him. He's a very, very different gentleman. And that's taken quite a bit of work. Sometimes community navigators don't need to do a lot, but that took quite a bit of work. But the distance he's travelled, and I have to tell you, about a third of the way along, he gave up his cannabis. And he doesn't seem to have anything the psychiatrist would be interested in at all now, to be honest. And I'm seeing this gentleman restored in so many ways, and I'm seeing him well. And actually, as a doc, all I did was make the connection when I saw the iceberg appear.